Thanks for coming to the seminar today. Dan Touchette is not here today to introduce our speaker, he's the advisor for Kellyn, so I'm going to fill in. So Kellyn, as you know, of course, is in her second year of our PhD program and is a Takeda Adherence Fellow, and also in the second year of that program. Kellyn has a bachelor's degree from University of Illinois Champaign-Urbana in, I'm just going to guess, biology?
That's like everyone.
Biochemistry?
Biology.
Biology, see?
It's a good guess.
And of course, did our PharmD program, graduated with really high honors, I'm sure. So she was talking about, I don't know what you're talking about. Is it a project you did with Dan?
Yes, it is.
Okay.
Basically, we're going to talk about adherence and cost sharing, specifically when things are free.
All right. Sounds good. I like free.
Yeah, everyone likes free things. That's why maybe everyone's taking free things. Okay, great. So thank you for coming. This is a project that I started a long time ago, and it's taken a while to move this forward. We've had a lot of input from pharmacy students, and I'll just say up front, we're still, while this is like the preliminary results that we have, we're still looking to see if there's other data that we can, from this review, that we can analyze. So I'm going to present what we have so far. So first I want to acknowledge Dr. Dan Touchette, as well as the students who have worked on this project over the last year. So as we all know, it's no surprise, many of us are healthcare professionals. Healthcare costs are very high. They're rising, and it's creating a very large burden that's causing payers to look for options for reducing healthcare spending. And while one mechanism that's been in place for a long time that I'm sure you're all familiar with, as you may be exposed to it yourself, is cost sharing. So cost sharing is a very common mechanism for reducing health spending, but over time we've actually seen a greater cost being shifted towards the patient. Certainly not proportionally to the amount that healthcare has been rising, but there still is a greater burden being placed on patients. As you can see in a study that was done by the Kaiser Family Foundation, they saw a 77% increase rise in cost sharing from 2004 to 2014. Also, obviously, employer cost sharing was rising as well, but you can see that they're covering a smaller percentage. And this effect doesn't just happen for this was commercially insured patients. It doesn't just happen there. We're seeing rising out-of-pocket costs also for patients in the publicly insured patients as well, in the VA, in Medicaid, and internationally in single-payer systems as well. There's been the introduction of co-payments and co-insurance policies. Back in 1990 was the first introduction of co-payments into the VA system. As of now, it's up to about $8 or $9 per prescription. And then, surprisingly, most states now have copay policies for Medicaid patients as well. They are subject to certain federal maximum amounts. However, you can imagine that if you're on multiple medications and you're a very low-income patient, paying $4 a prescription, at least up to that potentially, could be extremely burdensome for you and your family. So we know that there are implications to cost sharing. That's been well documented in the literature. A quarter of patients report having difficulty paying for their medical bills. There's been a larger and growing percentage of patients who report actually foregoing their medications due to cost. We've also seen that it's been documented that an increase in cost sharing by about 10% is associated with about a 2 to 6% decrease in prescription spending. And as you would then expect, we have also seen a decrease in adherence. So one meta-analysis done in 2013 showed that there was an 11% increased odds of non-adherence for patients exposed to higher cost sharing versus lower. So now to kind of go back in history a little bit, where did co-payments come from, and what was the evidence that supported their implementation? Well, it kind of goes back to a very large randomized controlled trial that was done in the 70s that looked at the impact of health insurance on healthcare spending. And they randomized families to different health plans, which had different levels of cost sharing. And they looked at the implications on the effects on spending and health outcomes. And the overall result that they found was that when you increase cost sharing, as you would expect, utilization goes down. So, it's exactly the result that you would probably expect to see. And what they assumed when they looked at health outcomes, they actually, if you look at their overall results, they really didn't find too much of a difference in health outcomes. And there's a lot of reasons for that. If you look closer in the data, there were some differences, but they kind of made this assumption that, well, when you expose patients to more cost, that they are essentially shopping smarter, and that they're able to forego unnecessary medications or unnecessary services that they don't need, because they didn't see any adverse events, really. So what we know now over time, as this has been studied again and again, is that we know that patients actually aren't very good at determining what is effective and less effective, what are high-value services and what are low-value services, and that reduction in utilization happens across the board. It's not differential. And since then, we've also seen a number of studies that have now linked cost sharing to some adverse outcomes as well, like hospitalizations and in specific chronic disease states. So we understand that cost sharing, increased cost sharing causes decreased utilization and can affect outcomes. But now the question that we wanted to look at is, well, should prescriptions then be free? When we talk about reducing cost sharing, should there still be some small amount of copayment, or should the prescriptions be free? And the reason why we wanted to investigate that is because there's some really interesting literature coming out of the behavioral economics literature that talks about the behavior and decision making that happens when things are free, and that there might be a reason for some additional benefit of having a copayment beyond a cost decrease in cost spending or healthcare spending. So this concept has been studied in a number of different domains, and they refer to it as like a zero price effect or a special price of zero. And so I'm going to just kind of go through one experiment that sort of illustrates what's been done around this topic. So in this experiment, this is based on consumer demand for chocolate. Very simple experiment. So they offered two different options for choosing chocolate. There was a Hershey Kiss, and then there was an obviously higher value chocolate, like a Lindt chocolate, or I think they use Ferrero, I say that. And they priced them at 2 cents for the Hershey Kiss and 27 cents for the nicer chocolate. And when they offered it at that price, you do see that certain patients do spend the extra money for the higher value chocolate. When they decrease the price by the same amount, so they decrease each by 1 cent, so now you have a 1 cent chocolate and a 26-cent chocolate, you see virtually the same thing. There's no difference. The cost differential is the same, and there's obviously been no change in the value you might get from each of those chocolates. They're the same product. And so you see the same result. However, when they did it one more time and they decreased the cost by 1 cent more each, and now the Hershey Kiss is free, you obviously see this drastic increased demand for the free product, and a decrease in demand for the Lindt chocolate. And so, what does this really mean? Well, what has been shown again and again when they've done this is that there seems to be this almost behavioral overreaction at zero, where people are essentially purchasing something with less comparative value just because it's free. So, purchasing, obviously it's free, but they're essentially no longer looking at the differential, which is still the same, nothing's changed, and they're having this sort of overreaction to that. So how might this even relate to healthcare at all? Because this is chocolate. So, you know, what we want to know is there something, is there some way that cost sharing is influencing behavior and motivation in a way that's maybe preventing patients from, you know, utilizing lower value services just because they're given for free. So the other side of this argument, and something that is quite intuitive to people, is this idea of the effects of having no skin in the game. So this is sort of a different argument, but it still is an anomaly that happens potentially around zero, that I felt required some discussion. So in consumer research and normal finance analysis, there's this argument that people are more likely to consume a product that they pay for. So they have skin in the game. That's, I think it's a Warren Buffett term, but when you pay for something, you're more likely to utilize it. And this has actually been even used for us in support for nominal co-payments for Medicaid patients. So we were really interested in, you know, is that true when it comes to medication adherence? So, you know, just some of the theories behind this that I'll walk through. You know, these are all examples of certain effects that could be going on. The argument being that if you charge a price, the people who are going to purchase it are the people who are going to use it. Other theories are, this comes out of Richard Thaler's paper from U of C, that there's this sunk cost effect. People who, for example, pay money for a gym membership are more likely to use it even if they get injured because they feel tied to that cost that they've already paid. And then finally, it's this idea of that people might be equating value with price, and that something that has a higher price is assumed to have higher quality in their minds. They would be more likely to use it. So there's a lot of interesting literature about what happens at free, but this really hasn't been investigated in terms of medication adherence but it has been investigated in some other domains. And I'll just talk about one last study. This was done in Kenya, and the question was related to those topics that I just spoke about. The question was, will patients, how is the demand and utilization of insecticide bed nets for pregnant women in Kenya affected by cost sharing? So what they found was that when you introduced any level of cost sharing, demand went down, and you can see that. So people were not, these women were not picking up the bed nets as often. But what they did notice that actually it did not affect utilization. When they actually went to their homes to see if they were utilizing them, it actually didn't affect it at all. We still see the same proportion of patients utilizing the insecticide nets at home. So this kind of counters that argument that we would potentially see a difference in healthcare, but with all the nuance around it, we wanted to investigate if there's anything in the literature right now that looks at zero cost and its impacts on adherence, and whether or not any of these theories support or contradict that. So to answer our question, we performed a systematic review, and we were looking at the impact of zero cost sharing compared to usual cost sharing on medication adherence or persistence. So the studies that we were including were original research, and it needed to have some sort of cost sharing policy, some sort of cost sharing intervention, or cost sharing structure where a group had zero cost. And then the outcomes we were interested in were medication adherence or persistence. We didn't put a lot of restriction around the types of measures. We wanted to be inclusive because we knew that the literature was sparse in this area. We wanted comparative studies, so we wanted there to be some sort of not just descriptive studies. We did include single group pre-post designs, uncontrolled, again for the reason that we wanted to gather all the literature. Obviously, these are low quality studies. We didn't put very many limitations around the design. We wanted the main exposure to be a cost modification. Oftentimes, these cost interventions are applied in conjunction with some other co-intervention, but we did allow some as long as they were minor or applied to both groups, as long as it wasn't the primary objective of the study. And then we didn't put any restrictions around disease state, the drugs that they were studying, particular patient characteristics, or geography. One other group of studies that we found very commonly in the literature, but we were unable to include, were studies that had analyzed the effect of adherence on zero cost, but zero cost was included within a range. So they would compare like they would analyze like $0 to $10. We weren't able to distinguish the effect of zero copay there. So we used a two-pronged search strategy. We did a database search of a number of databases and used the key terms presented here, or variants of it. We also pulled all relevant review articles that we identified and hand searched their bibliographies for relevant literature as well. And then all these searches, were conducted between September 2015 and October. We repeated it in June to gather anything new that had happened during the year that had been published in the last year. After removal of duplicates, we went through a two independent reviewer process, pretty standard, and we moved them into a second phase of review if it was accepted by one author. We did have a lot of articles after the first round. A lot of what we were looking for wasn't identifiable in the titles and abstracts. So we went through a second rapid full text review in between the final full text to get a better idea or to gather the studies that actually met our criteria. Our final in-depth full text review was conducted by 2 reviewers, and the data was abstracted into a standardized piloted abstraction tool in REDCap. So here you can see the studies that are the flow chart for the studies that we included. Obviously, we had, after removal of duplicates, nearly 2,000 articles that we pulled. This is a common topic that's studied, but it's not very common that there's an analysis of zero copay. So we pulled a lot and we had to screen a lot. We eventually had narrowed it down to 16 original articles that we included in our qualitative synthesis. When looking at the studies, we knew that there's a large amount of heterogeneity between the studies, so we weren't able to do some sort of meta-analysis from this. So I'm just going to present the qualitative results. So we identified 16 studies. We actually pulled 19, but 3 of them were secondary analyses of one of the studies, so we linked them together. Most of the studies were observational. We did have 2 randomized controlled trials, which I'll talk about later. We had 3 quasi designs, like quasi designs, and we expected to see more of that, but most of them were observational cohort studies. In terms of geography, majority of the studies were conducted in the United States, but we do see some international representation as well. The study settings, which we refer to as where the cost intervention was being applied, the majority of them were just based on some sort of insurance policy change or some sort of insurance program. There were only a handful of programs that were being implemented specifically in a clinic or a health system. Of the insurance-based programs, you can see a large majority of them were public, but half of those were from international publications, so they were single-payer systems. We did have one of the articles we pulled analyzed Medicare patients. We were really disappointed to not have any for Medicaid, because that was a contrast that we were really interested in, looking at those very low co-payments compared to zero. However, no studies met our criteria. We did have a number from the VA though. So the eligibility criteria, so these are characteristics that they use to select patients into the study. by far most common, patients were selected based on some aspect of their drug profile. So patients who are on statins or patients who are on antihypertensives. And because most of these were done in insurance claims, there was commonly an insurance requirement as well. So if we look at disease states that have been evaluated in these studies, by far the most common that you see is cardiovascular disease. And this is predominantly looking at adherence to medications that are given for free post-myocardial infarction. So that's definitely the most common that you see that's been conducted in the literature. And then, as you would expect, in terms of specific drugs, we most commonly see them analyzing anti-hyperlipidemic medications and antihypertensive medications, which corresponds with CVD. Predominantly, this has all been done in statins. So statins are definitely the most commonly studied medication. So just a little bit of background on what types of interventions they were actually applying. Like I said, not many of them were clinic-based programs, but we did have one incentive-based program, which I'm going to talk about a little bit more. Clearly a different design than just offering something for free. It was like a rebate system. Majority were insurance policy changes or just the insurance design. So you see about 5 out of those 13 were just an analysis of the design. So patients were already receiving medications for zero, and they were comparing it to patients who have a cost. But 8 of the 13 were programs that were implemented. So patients went from having a cost to no cost. And some limitations around those studies. Most of them were opt-in programs, which raises some concern about the selection. And then we did have 4 studies that had minor co-interventions. These were applied non-differentially. However, that is a concern for the results of the study. In terms of the cost interventions that were applied, majority of the time they were looking at copay versus no copay. But there were 3 non-controlled pre-post studies that we did include. But there were some other ones that looked at different tiers of copay compared to zero. So the adherence measures that we looked at predominantly came from administrative claims. Like I said, we didn't put a lot of restriction around what methods they used. And you can see that in the table on the right, majority of patients or majority of the studies used NPR or PDC. Some analyzed refill gap and discontinuation, which we were considering more of like a measure of persistence. And self-report was seen quite commonly, often in conjunction with one of these other methods. Whenever you do an adherence study, you're interested in what the follow-up is to know whether or not they're able to capture real adherence. So it was pretty good. Most of the studies were at least 12 months long of follow-up. We did have one cross-sectional study, which is why that's NA. The sample sizes ranged from about 163 up to well in the thousands. I know that's not that informative, but majority of the studies had sample sizes over 1,000, so if that gets you a better idea. And the average age of patients that were enrolled in these studies was definitely older. You can see that a large majority had patients who were, the average age of the patients enrolled were over 60 years old. And these were all...
30 was older. I thought you meant 30 was older.
No. I'm nearly 60, that's what I was going to refer to. And then just looking at differences between the copay and no copay groups, these were baseline differences. We were a little bit concerned. We paid a lot of attention to socioeconomic status and income, as that's a clear confounder of the effect of cost sharing on adherence. So there were a lot of differences, a lot more than we would have hoped to have seen in the literature. So we paid very close attention to how they controlled for that as a measure of quality. We also saw some differences in the comorbidities that the patients had. And then you might be wondering, what kinds of cost sharing are we comparing to zero? it ranged anywhere from 50 cents to $75, but majority of the studies were analyzing copays right in the $8 to $20 range compared to zero. So I won't go through this, but this is just like a pictorial description of what the quality of the evidence was that we pulled. A lot of the studies had methodological flaws, particularly in allocation and in the confounding. And so this was something of concern when combining the results. So now I want to go through a few of the studies to give you an idea of some of the results that we found. These are some of the more higher quality studies. To give you an idea of what the evidence that's out there. So this is the landmark trial that first investigated this topic. And some of you may already know this study. But what they did was, it was an investigator-initiated study that partnered with Aetna, and they randomized different plan sponsors to provide medications for free to some patients. And these were all myocardial infarction survivors. And so they could receive any brand or generic beta blocker, ACE ARB, or statin for free or at the usual cost. So the results were that they found that compared to those with usual cost sharing, which was on average between $12 to $25, they found that there was greater adherence, a greater difference in adherence, and an increased odds of adherence defined as NPR over 80. And those were significant differences. One thing, they did look at health outcomes as well in this study. They did not find a significant difference in their primary outcome, which was a composite of major vascular events or revascularization. But they did see changes in their secondary outcomes, which were each of those variables independently. This was the study that also had two secondary analyses that was done. So what they did is there were two different stratifications. The first one stratified by race ethnicity, and the second one stratified by whether or not patients had a CABG or not. The results for the one where they looked at whether or not a patient had a CABG or not were no different than the primary results. So they saw the same effects of zero cost sharing compared to usual cost sharing, and it didn't differ by strata. And then, but more interestingly, and if you look at the analysis that looked at race ethnicity, they found that the effects on adherence were the same. We still see that there was increased adherence for those who had free medications, but there was a difference in the outcomes. So they actually saw a difference in, they saw a decrease in the risk of secondary events in the non-white group. So that was a major takeaway from that study. However, only 41% of their full sample reported race ethnicity, so it's a limitation of that design. The second study I want to talk about is it was the other randomized control trial that was done very recently. It's called the CORD trial. And this was an incentive-based program through the VA. And they randomized patients to either receive 100% of a rebate or the regular copayment, which was $8 at the VA. So patients would pay up front, but they would be refunded the full amount. So essentially it was free, but they didn't actually have they had to fork out the money first. So the results of this study were that compared to usual cost sharing, those who had the incentive actually had no significant effect on adherence or on the odds of discontinuing the medication. So clearly there might be some difference here in the way that the intervention is delivered. However, this is just one study. They also did look at blood pressure in this study, and they saw that there was also no effect on blood pressure. Okay, the next studies that I want to talk about. These studies were very similar in design, but they looked at different medications. They were also conducted in the VA, and they analyzed the association between zero cost sharing versus an $8 per prescription cost sharing on adherence to statins was the first analysis, and then they looked at hormonal contraceptives in the second one. The most interesting part about these studies and why I wanted to present them is that this was the only study that's stratified by income. So we were able to see how these cost-sharing effects differ by income quintile. So the results that they found were that for the statin analysis, that having a cost-sharing actually was associated with the decrease. Having cost-sharing was associated with a decrease in absolute adherence, but only in the second and third quartile. However, when they went back to do some like post-analyses, they found that when they controlled for certain variables, there was also a significant effect in the first quintile. So in their primary analysis, they didn't see it, but they think that it was they reported as just being a factor of confounding. But we did not see any difference in adherence for higher income patients, which you might expect, you would expect this result. Interestingly, though, when they looked at hormonal contraceptives, they saw that there was a difference in adherence, but only in the highest. There was a decrease in adherence for patients who were in the highest income quintile, which is sort of interesting. So we are seeing that higher income patients were being affected, their adherence was being affected more by this cost sharing difference than lower income patients. In terms of reasoning, the authors really provide no discussion on this topic, and I've done a little bit of thinking myself about why. It could be something related to the fact that these patients are a lot younger. They capped their age at 45 because it's hormonal contraceptives, but it's an interesting finding nonetheless.
Kellyn.
Yeah.
Can I just ask you, you're saying medication adherence, is that, did they measure adherence or is it just medication possession?
Oh, so that's a limitation of all of this. Almost always it's just medication possession,
Okay.
but as a proxy for adherence. We don't actually know if they're utilizing the medication.
Okay. That's just a huge kind of.
Yeah.
Yeah.
Well, yeah, we'll talk. I want to talk about it again at the end. Okay. So the next study that I wanted to present, and we're almost done, just two more, was a analysis that occurred in Canada. There was a co-payment policy that was introduced, raising co-payments from 0 to 25 Canadian dollars, which is a very large jump. But they also analyzed it in two different medications. So they looked at statins and then they looked at beta blockers. They found that there was a significantly lower percentage of patients who were adherent 3 months after the policy change if exposed to the cost sharing compared to those who weren't. And you can see that the results were different though when they looked at beta blockers. They actually didn't see a significant decrease. So that's an interesting finding as well, that there seems to be some drug-specific effects as well. They also, just as a side note, they also looked at whether or not it decreased initiation of medications. What they did is they separated out the patients who were starting these medications because they had just had a MI. And then they looked to see whether or not there was a difference in the initiation of these medications, and they didn't see a difference for either analysis.
Can I ask you, did they, Dr. Sharp started?
Oh, okay.
Wait till the end.
No, it's okay.
She knows me. Ethically, was there any problem with that study?
Well, so what do you mean in terms of, eventually all patients had the same copayment?
Well, more so they were post-MI and obviously a difference in adherence. So to me, that's when the DSMB comes in and says, stop that study. Yeah.
Well, one thing, no, a limitation is they use a historical control. That's the key. So they actually analyzed patients. It was a cohort before any of the policies were implemented and then after. So But good point. I mean, for all of this, there's certainly a ethical consideration. It's not, you can't just randomize people to have cost or no cost. Okay, and then finally, the study that I wanted to just present was a VBID program. Many of you probably know what VBID is. Essentially, it's a new insurance design that's goal is to tie financial incentives to the value of the product. So this employer implemented a program where they eliminated co-payments for diabetic patients. So it eliminated the cost of their diabetic medications as well as their hypertension medications associated with their diabetes, obviously. And they looked at, let me step back. There clearly were differences because they actually analyzed their whole cohort, and they analyzed patients who participated in the program versus patients who didn't. So there's clearly a difference there. So a couple of the mechanisms that they used, they matched patients. However, notably, they did not match on income and socioeconomic status, but they matched on other variables. And they performed a difference in difference analysis to try to control for some additional compounding. But there's a clear limitation in the fact that there's something different about the patients who aren't participating in this program. The program required a wellness program visit. So that was the limiting factor. So that also confounds the study because there was a co-intervention as well. The results showed that there was a lower change in adherence in the proportion of patients in the patients who were participating in the program compared to those who were not participating. Okay, so kind of to bring it all back, obviously I couldn't present all the studies and I presented more of the well-done studies, but just to kind of give you an idea of the overall assessment that we've made of the literature thus far, predominantly that there are not very many studies that adequately look at the impact of zero cost on adherence. The ones that do, there are 2 randomized control trials, but all other ones that do have pretty significant methodological limitations. Oftentimes, just the way the system is structured, patients are allocated to zero copay or having some cost sharing by income. That commonly happens in the VA because their copayment policy is based on, service connection disability, but also there's an income factor as well. And oftentimes that wasn't necessarily always accounted for appropriately. Also, there is this presence of co-interventions. Oftentimes, they don't just change the cost; they implement these broader VBID programs. And then there were some limitations to the control groups and comparator groups that they used as well. Generally, if we look at the evidence overall, we did see on average more increases in adherence related to zero cost sharing. Specifically when we're looking at the studies that were measured in administrative claims, but these rises are very small, pretty consistent with all other adherence literature, about a 2 to 5% increase. When we look just at studies who use self-reported adherence, they all showed that there was an increase in adherence, but the methods that they use were quite poor and not validated, so could potentially be subject to some bias. And then the last category of studies that we saw was this group of longitudinal studies that looks at, which really just shows that zero copay, that adherence is going to decline over time, but that zero copay sort of stabilizes it. So we're not necessarily seeing some sort of increase, we're just seeing a maintenance of adherence, at least within the window of follow-up. So some things that were not investigated very clearly in the literature, we really wanted to see more contrast between the difference between low copayments and zero. As I mentioned previously, that argument has been used that you should give people a little bit of cost sharing to make sure that they adhere to their medications. Well, we weren't able to see that sort of effect for small copayment versus zero because it wasn't done. And there were no studies that met our criteria that were from the Medicaid population. Secondly, what I mentioned earlier when we talked about those randomized controlled trials was that there might be some difference in the way the design of the program that impacts the results. I can't say this with any sort of generalization because this wasn't done in many of the studies, but I think it would be something to investigate further. as we know, that incentive-based program did not work. So going back to this idea of free medications, should we provide medications for free? Do any of these theories apply here? Really what we saw was that while zero copay may increase adherence a little bit, we didn't really see any sort of special effect of zero. We didn't see patients adhering less. We didn't see them saying, I don't value the medication because it's free. We didn't see any evidence of drastic increase in utilization because of free medications. But it's important to know that the way that we study adherence, we're not really able to get at that question very clearly in the way these observational studies have been designed. A common factor in understanding whether or not medications are, these theories around free medication is understanding not just demand, but you need to understand utilization. And claims is a major limitation to that. We actually have no idea if patients utilize the medications when they actually go home. They may just pick them up. One thing that I think would be more interesting would then to be looking at outcomes, because maybe we could make some sort of better idea. If people have better outcomes, we might be able to say that, make a better connection that they're actually utilizing the medications. But majority of these studies, except for the randomized controlled trials, actually looked at outcomes. They always just use adherence as their end outcome. So we weren't really able to look at that, but I think that that would really be a way we could strengthen this sort of, going forward to look at this with a little bit more rigor. So in conclusion, zero cost sharing did have an effect on adherence behavior, but it was, or in terms of administrative claims, but it wasn't really different compared to what we've already seen in the literature for just differential cost on adherence. We didn't see any evidence of that zero price effect. However, we do know that adherence also is affected by many other factors beyond cost. So it's challenging to isolate the effective cost on adherence because there could just be other factors at play. So that's all I have. I'll take any questions. Thank you.